والصلاة والسلام على خير خلق الله أجمعين. My great audience, my distinguished speakers, welcome to one of the special evening of Tuwaiq Summit Evening. أمسية من أمسيات قمة طويق. احنا كسعوديين صرنا نتفائل خيرا بالاسم هذا، فنختم العام هذا 2020 بأمسية من أمسيات طويق, talking about very special important topic around the healthcare transformation, which is value-based healthcare. For this critical important topic, we have very special guests with us today. We have Dr. Reem Bnayan, Dr. Shabab Al-Ghamdi, Dr. Hussam Al-Faleh. I will ask each of my distinguished speakers to just introduce themselves. Dr. Reem, we'll start with you.
السلام عليكم ومساء الخير لكل الحضور الكرام. وفي البداية أشكرك دكتور هادي for the invitation. سعيدة بوجودي معكم. أنا اسمي ريم البنيان. أنا I'm the CEO of the Center for Improving Value in Health. وحأعطيكم a little bit of an introduction to the center as we get started with the conversation tonight. I'm a neurologist by background, and I focus my clinical practice on a highly specialized area in MS.
Welcome, and thank you for joining us this evening. Dr. Shabab Al-Ghamdi, welcome. It's an honor to have you with us. Would you please introduce yourself?
Assalamu alaikum. Good evening, everybody. It's gives me a great pleasure to be with you tonight. As Hadi mentioned, my name is Shabab Al-Ghamdi. I'm the Secretary General of Council Cooperative Health Insurance. We are the private health insurance regulator. My background, I'm a family physician by background. I have a great interest on improving healthcare quality, and I'm honored to be with you today to speak about one fundamental of the national health transformation, which is value-based healthcare.
Thank you very much, Dr. Shabab, for taking the time from your very busy schedule to be with us this evening. And we have Prof. Hussam Al-Faleh with us. Prof, it's a great honor to have you with us. Would you please introduce yourself to the audience?
Thank you very much, Dr. Assalamu alaikum wa rahmatullah wa barakatuh jami'an. Thank you very much for the kind invite. I'm really privileged to be with you to talk about this very critical topic. My name is Hussam Al-Faleh. I am the acting CEO of the Program for Health Insurance and Purchase, which will hopefully be launched as the Center for CNHI, the Center for National Health Insurance. I am an interventional cardiologist by background, a university professor affiliated with King Saud University, and I'm really happy again to be with you all.
Thank you very much, Prof. Al-Faleh, for being with us. I know all my guests have very busy congested schedule, but they have been with us this evening to talk about the critical topic, which is the value-based healthcare. Before I start, I just want to remind you, it's all about أمسيات قمة طويق. It's basically to talk about health policy, procedure, things that important for us as the general healthcare practitioner, beneficiaries of the front line, and this evening is an example of the theme for أمسيات قمة طويق. Evidence-based evening, another evening that الجمعية والFM Hub is doing, and we talk about important topics for the practitioner. I want you to mark your calendar for January 27, where we're going to talk about exercise as a physical prescription for disease prevention and health promotion. And please also mark your calendar for March 27 to 29, where we're gonna, the Saudi Society of Family and Community Medicine and the fmhub.org, along with other sponsoring societies and governmental bodies, We'll be launching the first Saudi Chronic Disease Conference, so mark your calendar for that. And our very, very special, the Deep Dive 2021. This year will go hybrid from June 9 to 12. And it's gonna be, as you know, the largest gathering for family and primary care practitioners in the country. So mark this calendar. And without further ado, I will go to my first guest, Dr. Reem. What is value-based healthcare? You're the CEO of the Center for Improving Value in Healthcare. Would you please brief us on what does value-based healthcare mean and what is all this new Center of Improving Value in Healthcare? The floor is yours, Doctora.
Thank you very much. And really, I'm happy to be here tonight with this very special audience. Very happy to be في أمسيات. Which will allow us to have more discussion on the topics and the issues that are important to colleagues that are listening in. I'd like to share a few slides because I think sharing a few slides will help ease us into this topic. So I'll take about 10 minutes or so to walk us through two very important points. Why we're doing this, or why health systems are doing this, moving towards value-based healthcare. And number two, what this means to us, especially what this means to us in the Saudi health context. And then this will take us to the rest of the conversation for this evening. I always think that it's very helpful to constantly talk about why we're doing this, and especially in a conversation that we're having tonight, it's good to start at this point. لأنه, you know, this year has been a very strange year with the COVID-19 pandemic and all the changes that we've had and the change in focus and the change in the clinical activities that each of us are doing. So I wanted to start by saying that health systems are moving towards value-based healthcare to address big challenges. And these challenges are challenges that all health systems are facing, whether they're high income, low income, whether they're developed or developing, or whatever we would like to talk about, due to a few main reasons. And I'm glad, Dr. Hadi, you started with the announcement for the important event on chronic disease, because more and more people around the world are having chronic disease. They're getting older, they're suffering these diseases, and these diseases are getting more difficult to manage because they're more sophisticated testing mechanisms, more options for treatment, more expensive drugs. And anyway, even if we don't have more and more people getting sick, the cost of care is rising. So if we continue to do what we're doing, even if we try to improve it or lean manage it or do something creative around that, we would still not be able to take care of people as we go forward. So health systems, in the way they're designed now, are not sustainable. And the shock or the crisis of the COVID-19 pandemic that we had this year has been a real test. And there are many examples that we can talk about as the conversation goes through the evening. And then I have some slides that I don't want to spend too much time on, but I'd like to draw your attention to them because they're evidence of this. So there's variation in outcome. And the examples on this slide are from sophisticated health systems. The examples are not family medicine examples. And we'll come to that as the conversation goes forward, because chronic disease probably is more challenging when we speak about outcomes and outcomes that matter to people. Some of these examples are crisp when we speak about a surgical procedure like cataract. And you look at the bottom of the slide, I'll use my pointer, 36-fold variation in complications in Sweden. And Sweden is like one of the best health systems in the world. We learned so much from this health system. So this slide shows an example of variation. The next slide shows, it's really a nice one because it looks at health adjusted life expectancy. And it looks at life expectancy as an important measure of health in general. And so you can see on the x-axis is the health expenditure, and on the y-axis the life expectancy. And we would like to see the green line, but we can see that it's not the green line. The more we spend, not necessarily leads to better outcomes. And the extreme outlier on the far right of the slide is the US health system. And there's more and exciting information that we're learning from the COVID-19 pandemic that we'll be happy to allocate some other time for. I don't intend to spend more time here. These are just examples of countries, health systems, organizations that are moving towards value-based healthcare as a way to sustain health systems and keep health systems to do what they're supposed to do. So this is the why. And the same why as we transition to the Saudi health system, the same why is the reason why we're doing this health transformation. And this slide is important because it reminds us of the triple aim of the health system, what the health system is designed to do. And you know, I paused there for a second because I'd like for us also during this conversation to talk about things beyond the health system. And Dr. Hadi spoke about exercise, and this is very, very relevant to this audience. So triple aim, better health, and better health speaks about the population itself. Okay, sorry, I'm having a little interruption. Better population of the better health of the population, and better care is better health care. And then lastly, at a lower cost. Sorry. Sorry, I'm having a little interruption here.
أنا عندي تبغين شاي.
لا شكرا.
لا أوكي. بس خليني أنا في الصالة.
Okay, this is working from my office at home, and so I introduce my mother to you, which she's going to wait for me in a moment. So better health.
Among the panel as well, Victoria.
Yes, I'm.
Really appreciate your time and your family time that you're spending with us.
Yes, it's great. It's fine. It's an interruption to the flow of the conversation, but it's the nature of working from our offices at home. So, better health, better care, and lower cost, which represents the triple aim of the health system, and at the core of it is value. Now, the next, I mean, I know many of you listening to us have probably seen this slide 100 times, and I still like to keep it in my slide deck because it reminds, I mean, it again is a reminder of the complexity, the size, and the impressive nature of the transformation of the health system that we're undergoing. And this journey includes changing everything in our health system. And again, to the audience, and I bring with this the feel that we had during this year when we had conversations with the G20 members. When we talk to them about the transformation we're having in our health system, we further validated that this transformation is very unique. It's the first transformation we're having in our health system. It aims to improving the health of people, and it involves a huge budget. It involves a very large number of people. All of us are involved, many of us, and it's very much centered around public health and family medicine. And so this audience is truly the most important audience to be engaged in this. So What does value-based healthcare mean? And I'll spend just a few minutes on this because the intention is not to go through a big theoretical conversation. The intention is to say that the core meaning of value is the balance between outcomes that matter the most to the people receiving care relative to the investment, the cost, the resources, the effort that's put in there. This balance is the definition of value. And we have several different approaches to this definition. And the approaches, when the respected listeners and viewers today read things in the literature, you will find the authors speak about different dimensions. Nothing in the literature that addresses value is contradictory. It just depends on which element of the system they're talking about. And when we look at the left side of the slide, you see the most famous version of this definition, which is the Harvard definition. And the Harvard health system emerges from the US health system that is very much focused on hospital care, or what we call the meso system and the micro hospital care teams in the microsystems, the teams like in primary care or in hospitals that take care of patients. And as I transition to the meaning of value-based healthcare for us in Saudi Arabia, I give you an example of the European Commission. The European Commission, they published a piece that talks about what value-based healthcare means to the European Union. So they localized this definition, looking at the values in the European Union, and they included choice, they included societal value when they talked about that. And this is what we did when we thought about the definition of value-based healthcare for us in the kingdom. And I'd love for you to take a look at this paper that details it. And I'll walk you through in a minute or so the meaning of value-based healthcare for us, or the framework of this definition for us in the kingdom. And what we did to develop this was we looked at these various definitions. We had conversations with experts, a number of roundtables where we sought the opinion of experts, and actually both Drs. Hussam and Dr. Shabab were part of those conversations. And then we looked at things that are unique to us in the kingdom. The basic law of governance. We have 2 articles in our basic law of governance that address health. One addressing public health and one addressing the right for healthcare. We also know that we in the kingdom are part of the United Nations UHC 2030, which is commitment for universal health coverage by 2030. We also know that we have certain things in our society that are unique. I mean, we are very spiritual. We have strong roots in our religion. We have strong family ties. In addition to family ties, our immediate community is also closely involved in life. I mean, and we felt this deeply during the COVID-19 year, with when we couldn't go to mosques, when Ramadan, when we went through Ramadan, the whole experience of going through that further validated that is a dimension. So the 2 basic elements, as we said, are the balance between outcomes relative to resources that are put in there. And the 3 dimensions are the individual's choice, the individual's opinion and thoughts about what's important, what's, especially when it comes to decision making. The immediate community, which includes the family and immediate surrounding community. And lastly, the population. We are a national health system that cares for the entire population. So many decisions in allocation of resources and many decisions related to assessing outcomes at the level of the population are important. So this is the framework that we at the center proposed. We are now in the process of validating. We're happy to be discussing it today. We've discussed it at a number of venues, which takes me to talking for a second about the center. So we at the center are a national independent entity that is an enabler for continuous improvement in value and health. And we do this through a number of things. Mainly what we're doing tonight is sharing knowledge, influencing policy, building capability, enhancing transparency, and providing evidence-based advice. We aspire to becoming a internationally recognized entity as a catalyst for improving value and health, and we look forward to interacting with everyone in the health system and supporting, aligning the various players in the system as we go forward. I think that's all for what I intended to do. This is a slide that we can come back to depending on how the discussion goes through the evening. Let me stop sharing and bring it back to you, Hadi.
Okay, thank you very much, Dr. Reem. So, very promising future value-based healthcare. We have a completely dedicated body for this important concept that's going to drive the change of the healthcare industry. If I want to summarize in my own way what I understand from your great presentation, more money doesn't mean better care. And doing it better or lean of doing business, maybe not the way to go forward. Maybe we have to redo the healthcare delivery system in our country. I would go now to Dr. Shabab after this introduction about the value-based healthcare with this understanding that more money doesn't mean better quality, and just doing it clean will not cut it through. We would like to hear from you, Dr. Shabab, and your great counsel about how the CCHI going to help us reach our goal of value-based healthcare. The floor is yours.
Okay, thank you, Hadi. I think, Rima, you are inspiring us high. We think, that's a very, very ambitious goal. However, I would believe with the momentum of the national transformation that we are going through, with the momentum of the effort that I see from all sister organizations within the kingdom, I'm sure we will be able to achieve the goal. It's a journey. And do you see my slides, guys?
Yes.
Yes, Abu Saad, we can see it.
So with the startup that was mentioned by Dr. Rima, I think I agree. Throwing money in the problem will not resolve it. So I do believe that with the national transformation program that we are going through, and in particular the vision realization program for health, we think we have several enablers that could help to make this happening. One of the arms that could be another catalyst in addition to the improving value in care led by Dr. Reem, we think Council of Cooperative Health Insurance, who are the regulator of private health insurance, will play a major role in achieving that objective. Again, I'm sorry for the interruption. However, for moving forward, I think CCHI would be in a position and with a responsibility on how can we drive value-based healthcare in the private health insurance for our beneficiaries, who are almost 11 million, through their private payer, whom they are mature to a certain degree, and we'd like them to really adopt the value base as a principle on the way they deliver care as a payer. And those payers are complementing what Dr. Hussam is doing. So we will have two arms to drive value. One is the public payer led by Dr. Hussam and the team at the Vision Realization Office in Ministry of Health. And one is the CCHI as a private health insurance regulator to help private health insurance company to adopt the same methodology to achieve and aspire to the same target. So I will just shed some lights on what's our role. Maybe some of you guys, it's the first time that you hear about Council of Cooperative Health Insurance. Who's our population? What's our growth or outlook on the future? A little bit about our strategy that linked to value-based healthcare, and then also I will also define some of what is the value in terms of when we decide the benefit. You know, benefits is always or the extent of medical coverage. Sometimes we focus on very sophisticated services, however we forget the basics. So how can we really try to make the right prioritization on the way we deliver care? Because always you have a limited resources. Whatever you have in terms of resources, even the richest country, always you have a limited resource. So how can you make sure that the limited resources that you do have, or the resources that you do have, are spent on your priority for health? And I'm sure Dr. Rima has covered value in a comprehensive way, and then I will introduce some digital initiative that we are honored to do it on the behalf of the whole healthcare system, which called Nafis. So Council of Cooperative Health Insurance, they have several responsibilities. One of them is defining the benefit package for our beneficiaries. Also, we'd like to make sure whomever are entitled for private health insurance, they get it. And we penalize private employer who doesn't avail this to their beneficiaries or their employees. Also, we are mandated to protect the beneficiaries' health information and privacy. We make sure that there is enough payer and there is enough provider to create a good competition. We do a lot of risk equalization activity with the central bank. And also we are working with them to produce more voluntary or supplemental health insurance packages. We think of partnership between the patient or the beneficiaries and the payer that will shoulder some of the responsibility and maybe influence the behavior of the individual in some way. We do licensing and qualification for health insurance company, and we are building their capability to move toward care management and develop their capability toward having population health program for their beneficiaries. Also, we are classifying and certifying provider to incentivize better care. So in 2010, we are still very young market. In 2010, we were having 3 million beneficiaries. Today, we have 11 million, and we anticipate by 2030, our projection, the people who have private health insurance will be at 21 million. Because as you know, the government are embarking in a bigger transform program, which is focusing on the private sector. So the biggest employer in the future will be the private sector. So any private employer, he's mandated or they are mandated to provide a decent health benefit coverage to the employee and their dependent. The contribution to the GDP is great. So there is a good opportunity to provide the value care in addition to help our economy to prosper. In addition, we are also providing health insurance for emergency medical coverage for our visitors from all types, either business, tourist, or Umrah and Hajj. That's kind of a detailing how we're gonna grow. We have several scenarios. However, we chose the modest one. This is our growth over the last 10 years in comparison to other countries. I think other countries who are maybe more mature in private health insurance has grown enough over the last 100 years. Since we are in the startup phase, so this is expected. Over the upcoming 10 years, I would believe the numbers will double in Saudi Arabia in terms of people who do have private health insurance. We expect, maybe Dr. Hussam can elaborate more, by 2030, the population of Saudi Arabia will be around 44 to 45 million. 50% will be private health insured and 50% will be public covered through the National Center for Insurance. These are our current number. We have a lot of employers. We have 560,000 employers in the kingdom. That's the size of our economy. Since we are one of the G20, we think the number will increase with the time, with the enhancement that the government is doing in terms of bringing investment and expanding the market and easing the investment. The number of provider now, we are 5,000 provider. We are looking to have all in kingdom provider, public and private, in our network. Currently this year, we have 13.2 million of beneficiaries. 2 million of them are visitors. We have 25 insurance companies who are providing health insurance in addition to a TBA and RCM. And TBA and RCM are very important to capture activity. We will know at the end, no value, cannot measure value unless you have a good digitalization. Those companies are specializing in how to improve coding and how to improve capturing activities. These are the size of services that we render through private health insurance, hundreds of millions of outpatient, inpatient, and other services, lab and radiology and pharmacy. So we build our strategy around our stakeholder, in particular our beneficiaries. It was really an extensive exercise with, like, as we say in hospital, we are patient-centric. In our strategy, we're stakeholder-centric. So we focus on the beneficiaries. We focused also on the employers because beneficiaries need equality and services, and employer need an affordability so they can continue to pay the premium for their employees. And they need to expand and grow and hire more people. So our responsibility to keep it affordable for all business type, either small business, medium business, or large and mega business. Also, other stakeholder are the employer and the payer and the provider. And as you can see, always the relationship between the payer and provider, it's a bit tense. I think that kind of tension is good to improve efficiency and to improve quality. However, we are now in a process to improve this relationship and make it more of a productive relationship and a win-win situation. We look to the macroeconomics, we look to the transformation of the kingdom, and we aligned with that. And we came with a 5 strategic pillar where we really focus on our population and our business owner as beneficiary-centric. And the second pillar of our strategy, or objective of our strategy, how can we make the relationship between the payer and the provider are productive and win-win for all parties. And we are working also on building the biggest infrastructure infrastructure platform, and they're gonna explain it in the upcoming few slides, in addition to improving our regulation to ease the business and the expansion and improve the quality. We think of ourselves as part of the Figure Realization Program. As you know, the Figure Realization Program is one of the major programs in the kingdom to transform the health, not only for the public sector, also for the private health insurance patient. And their mandate to improve access, to improve quality. And as you can see, the second strategic pillar on the VRB is improving quality and efficiency of health services. This means really value. So it's at the center of, at the highest level. Also, promoting prevention is essential part of the National Transformation Program, and this speaks very well to the community, to caring community, and also to primary care, especially. We know very well if we have a very comprehensive primary care that focus on prevention, focus on chronic care management, focus on the psychosocial aspect, the value in care will improve dramatically. That's why the Ministry of Health and other sectors are investing heavily in building a better infrastructure for primary care and qualifying more family physicians. And I'm glad to see more people now are getting in the family medicine program. The private sector will not be different. We are also pushing toward driving the care from the hospital to the community. And we are engineering this through several venues. One is really defining the benefit package, recognizing primary care, reducing the copay when you go to primary care or making it zero. And these kind of changes will drive the flow to the primary care. There is several tactics we are adopting to get us to value. One of them is really focusing on prevention and the primary care. One of them is really focusing on how can we measure the outcome. How can we move from paying for service to pay for performance? And all of those kind of dimension needs several tactics to achieve it. And there is a project on the pipeline for the private health insurance, and I'm sure Dr. Hussam is working on the other side to help also to build those foundations in the public sector. So we conclude that we are not anymore just a private health insurance regulator. We would like to really to move toward being an international lead in achieving best value in healthcare for beneficiaries of cooperative health insurance or for CCHI population. And it's not anymore treating people, it's really improving the health of people. That's why our mission speaks to that. And I'm really very optimistic about the alignment that we do have now with the public sector. And I'm sure we will achieve those kind of objectives for the total population of Saudi Arabia, regardless of the buyer, whether they are publicly paid or they are privately paid through private health insurance. So those are our 5 strategic pillars. We talk about beneficiary-centric, enabling the sector, and how can we drive more value and learn from our colleagues and learn from national and international experience, and how can we see when it's the right time to apply some of those principles. And we think of ourselves as a progressive regulator. That's why we are changing a lot of our org structure, and we are bringing international talents to our pool of talents within the CCH, and we are building the biggest digital platform in the kingdom. So these are examples of the program that we are running, and we are committed to our board to provide them with measurable outcomes. So we measure the healthcare outcomes. Also, they'd like us to measure the outcome on our strategy, and are we moving on the right target or not. So schedule of benefit is part of the value, even though it's really a bit of detail. But I'd like to share with my colleagues, the family physician, always we would like to offer all of our patients the best care. However, we need really to be wise on what to prioritize. So I do believe using services and rendering it to our beneficiaries, adopting the best clinical protocol will save the next patient, because you will have more resources to treat your next patient. So we have an moral and ethical obligation really to believe in value, because believing in value will help you to help more patients with a better quality. Okay, and as you can see, the benefit package is always the starting point. However, the administration of it through clinical protocol, through measuring the outcome, will help you really to define the value chain of value. So you start by defining what you will be able to cover and not to cover, and how you're going to administer it, and how you're going to measure the outcome, and how you're going to pay for it. without going on the details, I'll just shed some light on these are some of the slides that I steal from Dr. Reem Al-Bnayan. But if we look to how can we move from paying for service to pay for performance, we need to bundle care together. See, this is a kind of the value chain of care. You know, we'll pay for visit, then we'll pay for the procedure, then we'll pay for the follow-up, and then we'll pay for the readmission. How can we bundle this together and improve the accountability on the provider, and then incentivize them based on their outcome? By this, the good provider will stream his process, provide a better care from the first time, have the best talent to do the procedure, use the best material, and then can brag about the outcome that he's coming up with. In addition, he will be incentivized through certain payment scheme that we are designing now. As you know, in Saudi Arabia now, we are using fee for service, not even DRG. Our mission at CCHI is to move from fee for service, paying a line items by line items, to bundle it in a DRG. DRG is a very recognized formula of payments that been utilized in a lot of countries for the last 20, 30 years. It reduced the length of stay, for example, in US by 50%. And that's still a fee for service, but at least it will bundle the care at the level of DRG. The second level of bundling is really how can we make sure we give a warranty on the services. We include the complication, possible recognized complication in the bundle. So, and we call this bundle where you include the procedure, the possible recognized complication, and then you increase the payment to compensate for the expected recognized complication as per the international incidence rates, where then you incentivize the provider to do their best to keep their recognized complication the acceptable standard, and to incentivize them if they do better than the benchmark. Dr. Reem has really mentioned several successful examples. So it's a science, value is a science, it's achievable as long as you have the will, the system changes that you need, and also the tactics that you can build on. So how can we measure outcomes that will incentivize good provider and will encourage low performance provider to do better? It's really by measuring their performance, and measuring their performance will not happen unless we start to digitalize and collect data. That's why we are building the biggest national national platform called NAFIS, NAFIS National Platform Health Information Exchange Services. NAFIS من نفيس وغالي. It will have two major components, which is the exchange between the buyer and the provider, where the provider will ask for the approval on this platform. They will receive the approval from the buyer. We will adopt on this platform an approval support decision algorithm that will help to have the right approval timely. And then we'll collect the data to compensate those providers as a claim, which will help us to measure their performance. So this is just
نفيس هي المنصة الوطنية لخدمات تبادل المعلومات الصحية. مبادرة
يعني الفيديو وقف يا ابو سعد.
أطلقها مجلس الضمان الصحي التعاوني بالتعاون مع المجلس الصحي السعودي والمركز الوطني للمعلومات الصحية وبالشراكة مع وزارة الصحة. نطمح من خلال المنصة إلى تحويل منظومة الرعاية الصحية في المملكة العربية السعودية من خلال استخدام أحدث التقنيات لتعزيز مستوى وجودة الخدمات الصحية وتوفير بيانات موحدة دقيقة ومكتملة تدعم تحقيق نظام المجموعة المتعلقة بالتشخيص DRG والرعاية الصحية القائمة على الجودة والكفاءة Value-Based Healthcare. وتحتوي المنصة على خدمات التأمين الصحي الرقمي الموحد، وتهدف الخدمة لعمل حلقة وصل تربط جميع مكونات النظام الصحي التأميني كشركات التأمين والمستشفيات والصيدليات وغيرها من المستفيدين بشبكة معلومات واحدة يسهل الوصول لها. الخدمات الصحية وأهمها الملف الصحي الموحد للمريض، بحيث يربط مقدمي الرعاية الصحية بالمملكة بنظام يسهل عمل الممارسين الصحيين ويعزز من الصحة العامة. تهدف منصة نفيس إلى تحسين الخدمات المقدمة للمستفيدين والجهات المعنية الأخرى عن طريق أتمتة وتحسين الإجراءات لتقليل الهدر التشغيلي وتعزيز جودة وكفاءة الخدمات المقدمة. حوكمة قطاع التأمين الصحي ورفع مستوى الالتزام بالسياسات واللوائح. توحيد اللغة والمعايير المستخدمة والتراميز الطبية في التعاملات الصحية والتأمينية وتوفير بيانات وفق منطق يدعم اتخاذ القرار. ولتحقيق تلك الأهداف تتبع منصة نفيس نمطاً محدداً في طريقة عملها، والتي تعتمد على عدة ركائز أساسية، وهي الربط، حيث أن كل الجهات المعنية والمستفيدة ستكون مترابطة عبر الشبكة الرقمية. الوصول المشترك، وذلك عن طريق وضع وتطبيق معايير وطنية لترميز الخدمات الطبية. القدرة، والتي تتمثل في إمكانية إدارة عدد كبير من التعاملات بسرعة والاستفادة من المستحدثات التكنولوجية، وأيضاً ممارسة العمل بكفاءة عالية. الحفاظ على الخصوصية والأمن السيبراني، وذلك بالحفاظ على سرية المعلومات على مختلف مستوياتها المسؤولية، بتوفير البيانات أولاً بأول وتحليلها لتحسين الإجراءات ومخرجات النظام التأميني الصحي. نفيس.
طبعا أبشركم المشروع الحمد لله انطلق، وبدينا بالجزء الأول اللي هو التعاملات التأمينية الصحية. We started them. I switched to Arabic because of the influence of the video. So we started with the first part, which is to help to improve the exchange between the private health insurance company and the private provider. This will help us to really serve the customer better, collect the right data, and build the foundation toward DRG. The first approval actually is happening this week. So that's a good moment to announce this and to celebrate it with you. I do believe this will continue for the upcoming year. So we are expecting by the end of 21, we will be able to have all insurance patients are served through this common platform. What will this do to value? It will provide the right data, will provide the right priority for us, will provide some outcome measures. I attended the ICHOM 2 or 3 weeks. ICHOM is the International Consortium of Healthcare Outcome Measures. Every speaker during that conference, which is an international conference that focuses on value and building the measure standards for and how to measure value per each medical condition, and maybe Dr. Reem and Dr. Hussam can elaborate more on the ICHOM initiative. Every one of them are talking data and digital. So definitely, I cannot speak more about the importance of how can we collect the right data to measure the right metrics so we can define our priority, then define the outcomes that we are looking toward, and then improve it. I am sorry, Dr. Hadi, I think I took longer than what you expect. However, it's really, again, my pleasure to be with you tonight and to receive any questions whenever you open the floor.
Thank you very much, Dr. Shabab. Very inspiring, and congratulations on the release of Nafis. And thank you for sharing this news through this event. If I want to summarize quickly what mentioned by Dr. Shabab, bundle payment or pay for performance, digitalization, and outcome measurement. So these are almost three critical components of the 6 domains of the value as the outlined by Porter, who's the father of the value-based healthcare. So this is very inspiring, and I don't want to spend too much time, but I really, if it was not for this event, I would spend more time on what you mentioned about how private healthcare sector and industry is emphasizing on the population health and in the primary care. I think this is a big paradigm shift in the private healthcare industry. So thank you very much, Dr. Shabab. Now we're going to go to the biggest buyer.
If you allow me, Hadi, I'd like to send a reassurance message to all primary care physicians. I am a family physician, so I will be your ambassadors to promote for primary care. And our chief medical officer is also another family physician. So, and I think the science and my colleagues, specialist colleagues, they believe, the only way to deliver quality care with a cost-effective way is really through community care or through primary care. Thank you, Hadi.
Thank you very much, Abu Saad. Abu Abdurrahman, the biggest buyer in the industry, in the healthcare industry, the government, how is the MOH through FAB gonna drive the transformation through value-based healthcare? We heard the general concept from Dr. Reem, then the private industry from Dr. Shabab. It's your turn, Dr. Hussam, to tell us about the big picture MOH going through the transformation for value-based care. The floor is yours.
Thank you very much, Dr. Hadi. I don't think I have really fancy videos like Dr. Shabab or beautiful slides like Dr. Reem's slides, but I'll try my best. I think that before I speak any further about the program for health insurance or CNHI in the future, I'd like to go back to basics again. And I think that given the fact that that the audience that are listening to us are physicians, primary care physicians, family physicians, I think as practitioners, it is extremely important to emphasize the why again. And why do we need to change? I think is really the real question. We could talk about technology, we could talk about new approaches to payment, but I think all of these are going to be just simply levers, enablers, and unless we understand why we need to change, none of that is going to stick, none of that is going to work. And so I'd like to pose this question: why do we need to change, and is the current model really delivering us? And allow me to just share some slides that I think might help in that narrative. Is the slide deck clear?
Yes, Doctor, you can maximize your screen.
So, it's not all gloom and doom. We're doing very well as a healthcare system, Dr. Hadi, and I think that we should be proud of the system that we have. Over the last 50 years, we've had tremendous changes, breakthroughs in our healthcare system. Be it public health care facilities, academic institutions, number of professionals, but also outcomes. I mean, vaccination is really exemplary, what we have right now in Saudi Arabia. Infant mortality rate reduction and life expectancy. It is really remarkable where we're at. But the issue is this current model that we have that delivered us over the last 3, 4, 5 decades, will it work for the coming 3 or 4, 5 decades? That's the real question. And being a physician, I draw my energy primarily from my patients, and I still practice very proudly every week, even though I work at the payer. And therefore, I think what anchors me are the cases that I see. And given the fact that the audience are physicians, let me take you back to basics. And let me just share with you 2 cases. And I apologize for those who heard these cases from me before, but I will go over them again. So let me just tell you about Ali's story. And this is a patient that, this is our cath lab. I work at King Khalid University Hospital. This is the cardiac cath lab. I'm an interventional cardiologist. And on that cath lab, I entered on my day to see this patient sitting up, and they were preparing him. And as I came in, he shouted my name and asked me, Dr. Hussam, and I didn't recognize him to start with. But then it became very clear that I saw him in my clinic 3-4 months prior to him coming for the procedure, for the cardiac cath. He was admitted with an MI just 1 day before. And I remembered he told me that I came back to you. And the discussion that happened between me and him in my clinic was that, Ali, you're a smoker, you don't take your medications, you're overweight, your blood pressure is high. Do you want another myocardial infarction? And he told me, no, I don't. So he came in about 3-4 months with a myocardial infarction. And I think these cases that I see, and I still see, unfortunately, just emphasizes the fact that we're not doing a good job. I mean, I could be cathing him, putting stents, but I don't think that I'm doing much to these patients. Let me take you to the next patient, and this is not her picture, and that's not her name, but she's an actual patient. So this patient I saw in my clinic as a referral, as a preoperative assessment. She's going for bariatric surgery, and they wanted me to clear her for surgery. And so I did this, and we went through the investigation, and I wrote down, I was, documenting on the chart that she's clear for surgery. So I told her, you're fine, everything is fine. Your physician's going to look at my note, and he's going to take it from there. So then she stopped and she started asking me these questions. يعني بالعربي, متى عمليتي? When is my operation? Where do I go? I asked her, who's your surgeon? I don't know my surgeon. Where's your appointment slip? What appointment slip? It was really a disaster, حقيقة. And I think I am absolutely sure that every physician in these 1,700 that are attending today, I'm sure they see this every day. And so the question is, this patient is completely lost, and I'm lost with her. And I think that these questions I ask myself is this a unique case in our healthcare system? And I think the answer is no. Is she getting value for her care? Are we delivering value? And I think the next question is, if we're not, what is going to deliver us? Is it going to be Lean Six Sigma, TQM? Do we do customer support? Do we actually create a customer support portal? Will actually process improvement deliver Nora, the patient? And the other question is, more specifically, is obesity surgery the right choice for Nora? Is it the effective intervention for her? And was the care process designed around her needs? And is really surgery the right approach? And if it is, what kind of outcomes do we aim for? And then finally, if we agree on all of that, what kind of payment model later on would actually create value in the care of Nora? And so these are all questions that I pose to myself and to you. And I guess the ultimate question is, are we doing the right thing right? That's the real question. And if we take these different challenges that I'm just showing you in the screen, I mean, this is a burning platform that we're in right now. We have a spying healthcare cost, and that was clearly shown by Dr. Areen. We have an aging population. Is our system designed to deal with this aging population and those with chronic disease? We have a very unhealthy lifestyle. I mean, I'm a cardiologist. I can't convince my son to follow a healthy lifestyle. And I don't know how we could do this in our system. With our system, is it designed to help? It is designed to deliver healthcare, but is it designed to promote a healthy lifestyle? There's low visibility understanding about healthcare needs in the population with no much in the way of data. there is even lower visibility on cost and inefficiency. And I think that Nafis, that Dr. Shabab pointed out, too, will hopefully help us with a lot of these questions with the data. No strategic purchasing of defined healthcare services. We don't have really strategic purchasing. The way we purchase services is not efficient and does not actually promote value delivery. And there are no incentives, active incentives for providers to improve cost structure, patient satisfaction, and delivery of value. Nothing incentivizes right now in the system providers, myself and all the audience right now. Let me just take you to some examples, more concrete examples about what Dr. Areem just mentioned about variations in care. And that is the crux of the matter. And if you look at this map of the United States, this just shows you the percentage of obese individuals in different states. Dark red is 30% or more, and then you can see the variations in the prevalence of obesity. But when you superimpose bariatric surgery rate, you'll find that they don't superimpose. And so what is going on? How come some places where, for example, there are low obesity rates, there are high bariatric surgery rates? So that's one question to ask. I don't know what's happening in Saudi Arabia. If you look at variations in outcomes, it's a completely different story. These are centers of excellence in the United States. If you look at the variations, the huge variations in outcomes, and this is across the board. If you come to Saudi Arabia, for example, and you look at diabetic gangrene, amputations for diabetic foot. Now, you could argue that this variation could be because of low data reporting, but nonetheless, it poses the question: is it really low reporting, or is it really variations? Well, how come is Al-Ahsa? Why is it that they have more amputations than Riyadh, for example? I don't know. The issue of cost growth is another area. We know from the data that we have a rising cost on a yearly basis, 6 to 7% per annum increase in cost. This is unsustainable. We cannot continue like that. Definitely nothing, increasing efficiency only is not going to actually reduce the cost increase over time. And you asked this question to Dr. Shabab, and he answered that. I'd like to expand on it. Throwing more resources, will that actually lead to better outcomes? And the answer is a resounding no. And this is the law of diminished returns. And in fact, in healthcare, we know that the more resources that you put, you don't necessarily get more benefit. In fact, harm goes up as you put more resources. So doing more cath, doing more surgery is not necessary. Opening more hospitals does not lead to maximization of value. And so I think that we went through different paradigms in our lifetimes just to answer this conundrum that we're living in. And we went through cost effectiveness, we went through the evidence-based medicine, paradigm, quality and safety, and now we've arrived at value. And I think that that's really the primary reason for why one key strategic pillar or objective of the transformation. And by the way, although I represent the payer entity, the future payer entity of the system, Dr. Shabab is the regulator of the private insurance. We are only mere levers. We cannot answer the question of delivery of value without having everybody on board. So one key strategic objective of the whole transformation is in fact value. تحسين القيمة المحصلة من الخدمات الصحية. It is a strategic objective, and to that end, 6 programs transformational programs were actually developed. FAB, which I represent, Program for Health Assurance and Purchase, is one key one. And our mandate is to enable financially sustainable, value-based healthcare system. That is what we stand for. This is what we talk about all the time. In fact, I'd like to say with pride that even CIV, that Dr. Areem right now is the CEO of, is actually incubated by us because we believe that unless the agenda of value is advanced, we cannot do anything. And I think Dr. Arim, through the center and the support that we're trying to provide with her with, hopefully will improve that, will create the right agenda. So the key change in the system right now, the structural change, is that MOH, which does everything right now, delivery, provision of care, regulation, and purchase of services, is going to separate out. You need to create that tension. You need to create that separation. A payer entity that is separate from a provider entity. They cannot be the same. There is going to be conflict of interest, and hopefully that will be the starting point to the change that we want. I think that to conclude here about the transformation and our strategic direction, this is in essence what we're trying to do. We're trying to move from a hospital-based model, and I'm sure that your audience, family physicians, are going to be delighted to hear this from an interventional cardiologist, is that we want to move from a hospital-based model into a beneficiary-centric model. And that is the essence of the new model of care that was developed. I'm really proud to be part of it, Dr. Arim as well. And we're moving from focusing on therapy, on treatment, to prevention, focusing on expansion of services, more hospitals, more cath labs, more ORs, into actually focusing on quality and efficiency of outcome, moving from a budget based on a number of beds into a number of beneficiaries and health risk profiles of the beneficiary pool, moving from a disconnected healthcare system that doesn't actually help Ali or Nora that I told you about into an integrated and coherent health service, and building a legacy on the legacy of experience. We need a learning system. We need to institute a learning system, and relying on scientific evidence, digital analysis, and supported by artificial intelligence in the future. And then requiring the patient to go to the service provider rather, and instead of that, actually moving to a 24/7 continuous and effective care using digital and virtual tools. And we already have, alhamdulillah, elements of that in the system. So with that, I'd like to stop, and I'm sure there's a lot to talk about, but this is at least, this is where I drive my passion personally, and I hope that also would drive the passion of the dear attendees. Thank you very much.
Thank you very much, Dr. Hassam. Truly, you speak and present like a family physician who speak about Noura and Ali as we do in the clinic every day. Like you would ask me what is your specialty without knowing you, I would put you family physician. Like you connected us to the why, which comes at the end of the day to talk about Ali and Noura. Thank you very much, and we really very motivated by the why that you presented to us. Okay, now I'm gonna just to clarify one point. Our audience are mixed of physician, nurses, and patient as well. So majority are primary care, but we have lots of people who are non-primary care. We have audience, I'm receiving questions as you speak from UAE, from Philippines. So we have quite diversity of audience. And thank you very much, speakers, for tackling the issue from different angles. I will come to you, Dr. Arim. I want to take Ali and Noura. Dr. Shabab is talking about the private and CCHI. Dr. Hassam is the main player. Who you, as the Center for Employment Value, is the one who's going to talk Ali and Noura when you put the strategy. What does Ali and Noura rule, how you can see them involved in driving the value of basic healthcare in this transformation, the patient, the end user of the service?
Thank you for this question. Ali and Noura are the subject of this entire topic, and the ultimate objective of this whole conversation is to have Ali and Noura with us on this panel, speaking about this and speaking about their perspective of what they what they would like to see from the system, not only the health system, but the entire system. And there, the perspective of both Ali and Noura in on their health, their illness, their role in their care for themselves to maintain themselves as healthy as possible and to take care of themselves when they're sick is extremely important. And this question that you ask is a question that all health systems are asking. And this is the foundation of what we just heard from Dr. Shabab on the data system that's going to collect and help us measure outcomes. The perspective of the recipient of care is extremely important, and defining it, two things, activating that role and defining it is going to be extremely important. Now, we started that, and I want to go back to what Dr. Hussam said about the model of care. When we redesigned the model of care and came up with a blueprint for the new model of care for us in the kingdom, we did this very big exercise. I remember, Dr. Hadi, you were with us in this, where we had a representation similar to the audience today. Physicians, nurses, allied health of all types, all sectors, all around the country, and patients. And the reason we had patients for this specific exercise is these were people that actually experienced going through the system and getting some care through the system. I remember as a national lead for chronic disease, we had a woman that was a recovered breast cancer patient. We had a father of a child with sickle cell disease. We had a mother of a teenager with type 1 diabetes. She used to come from Medina, this woman. She used to travel from another city for these workshops to have these conversations with us. Now, since it's Umsiat, if I can take us a little bit further, if you don't mind, a little bit further, and then have more of a discussion around this. I want to take us to the respected audience today, because I'm sure what's going through their minds is, what does all of this have to do with me? Or, bukra sabah, I'll wake up and I need to go to clinic and just do the same old thing that I do every day. And I want to bring Ali and Noura into this. And this is where the magic happens, where Ali and Noura meet one person from the audience tonight. That's where value is created, where the magic happens. And it happens, and relevant to this audience, it happens in what we call the clinical microsystem. It's like the team that's in a primary care clinic, the receptionist that receives them, the nurse aide that takes them into the vital signs room, the nurse that actually does the revision of the care program, the family physician or the GP that actually synthesizes the information and co-designs the care plan with Ali and Noura, and enables them, activates them, turns the switch on, or gets them to engage into that mode. And I can speak for myself, because I can say that I, as a clinician, I've transformed since I've become involved in this. My conversations with my patients have changed. I started to tell them, Anna, I'm your coach. I can only encourage you. I can only suggest what the care plan should be. And sometimes I joke with them and I say, I can't come with you to your house to give you the pills. Ya late, but I can't do that. I can't come with you to the physical therapy. I'm a neurologist, so we talk a lot about rehabilitation. I can't come with you to the physical therapist to do the therapy, but I can encourage you to do it. I can't, you know, smoking is an issue also for us, similar to family physicians. Is I can't make you stop smoking. So that's where the role of Ali and Noura is into this conversation, and happy to take it further as we go with the conversation.
Thank you very much, Dr. Shabab. With this nafis, strong IT program that's controlling all the transaction, I get a question from the audience. What about the CCHI rule and this transformation would come to the quality, monitoring the quality of care, not only the financial transaction?
I would like really to just reflect on what my colleagues said regarding on how can we help Ali and Noura. I think the system is trying to create accountability, starting with at the macro level. For example, the national buyer is trying to make the provider accountable. The private buyer, we will make them do the same rule, make the provider accountable. And I think the accountability cascade down to us as physicians. I remember very well as a practicing physician, sometimes you get busy on the clinic, you don't know, are you really making difference? Are you really helping your patient? I think now with the technology and with the toys at our hands, we can, for example, and you know, Hadi, when we work in a certain captive population, you know how many patients you do know. If the system helped you to know whom do have chronic medical condition, whom doesn't have, those who doesn't have screening program done for them, and those who do have. So you can then really be accountable at the front line as a physician, as a family physician. So you will split your time based on your portfolio. For example, we would expect all family physicians in the kingdom, they will care for 2,500 to 3,000 population. So if they know the demographic of their population, who's diabetic, who's hypertensive, and they start to really categorize them based on their control, and they start to really manage their care and treat them to make sure they achieve. I think that's the kind of accountability we are trying to create through the system by different means, by changing the whole regulatory environment, by measuring the outcome at each stage, and then we reinforce it through systems. So I think unless we have that business case in our mind, the digital will not resolve anything. So the digital is an enabler. It's not really the smart magic. It will not resolve issues for Ali and Noura unless we really create the right accountability at all levels. And I'm sure all of us would like to know, are we treating our patient well or not? How can we help them better? I think that the picture, we're gonna bring it to the physician. However, it's their responsibility really to take it further. It's the responsibility of the provider to take it further. And our obligation is really how can we incentivize good provider, good practitioner in a non-financial and maybe in a financial way, and how can we show those who are not doing well how they can do well. It's not really to blame them, but to show them their opportunity to improve.
Thank you for this insight. So IT is an enabler, it's not the magic that is going to fix everything for us. Dr. Hussam, Ali and Noura can be MOH, beneficiaries, can be private sector. At the same time, they can be واحد منهم في National Guard, one in military hospital, one in another different. So how is the MOH gonna help the transformation of Ali and Noura journey through value-based healthcare through all different providers, whether MOH or other main player in the industry? What's your input on that?
So طبعا our current model as the Center for National Health Insurance, the model focuses on MOH beneficiaries at this point of time. That's the mandate. The remainder of the beneficiaries from other governmental sectors, the private insurance, they are going to be covered and addressed through their programs, be it the private insurance or the entities that they are affiliated with. However, having said that, I'm glad to say that there has been an approval to proceed with the health sector transformation, developing a health sector transformation program. And the question that you posed just now about what is going to be, what about those beneficiaries who are outside MOH, what is going to happen with them? These questions are going to be addressed through this program, which I hope these questions will be available to us in a year's time, inshallah. I mean, I think that the issue of value and the concept of value delivery is going to it's going to be a global and a general change that will affect the system. And so it is not going to be something that is going to be only in MOH. So it is a full system, and it is going to be, and it's interdependent, and therefore we expect the change to happen. But going back to the question of Nora and Ali, and how do we address their issues? And I think that just to build on some of the points that Dr. Areem and Dr. Shabab mentioned, let me just put this slide on. Is the slide up?
Yes, Dr. It's up.
Yeah. So I think that's the question I ask myself, and that's the question. At least that's the answer that we think would be the answer for Nora and Ali. And I think it is going to be through value-based, through emphasizing value delivery. And Dr. Areem already addressed this in terms of what exactly is value. But I think that one key area that I think is worthwhile emphasizing is the fact that there are three foundational principles that the World Economic Forum has emphasized, which is that it is important that we look at care in terms of outcomes that matter to patient over the cost across the full cycle. That's one. We need to look at the population segment, such as Nora population, those with obesity, hypertension, or cardiovascular disease. Look at their outcomes and the cost associated with their care. And then, the third foundation principle is direct specific interventions towards that particular segment, and then measure what the outcome of that. And I think if you look at somebody like Nora, one key area that I think that is going to be emphasized in the future through different levers is that you as a physician working in your clinic or providing care to your patients, you're not only responsible for the clinical risk of the patient, addressing the clinical risk of the patient. Eventually, with the maturity of the system and as we progress forward, you're also going to be accountable for the financial risk. Because at the end of the day, Dr. Hadi, Dr. Areem, although we're Dr. Shabab, we're all physicians, we've been trained to be physicians, our actions matter in terms of cost as well. And it's not about reducing cost. It's about the fact that there are finite resources. We don't have all the money that we can spend. There are finite resources, and therefore we need to manage these resources properly. And if you're actually directing care or spending money on interventions that are low value, that means that is going to be on the expense of a high value intervention. And so we would like to look at the pathway of obesity, for example, of Nora, and look at the different elements of her care, not only in hospital, but across her, the complete care cycle, and address her needs and look at not only the interventions that we need to deliver based on her needs, but also measure the outcomes and the cost, not only of the hospitalization, but across the cycle itself. And that could take up to 2 years. And I think that without having an infrastructure to capture data, I think that is going to be very challenging. And therefore, I think that the enablement of tools such as Nafis, measurement, are all going to be key. These are only details. I think what is important is the mindset of the practitioner. If he does not, a transformation, let me just emphasize, the transformation, value-based delivery is not going to happen unless you and I as practitioners embrace this, take it to heart, and bear that burden of delivering value to patients. So what about, what are the enablers that we think as a public payer we will be working on over the coming few years? And by the way, these are not things that are happening right now. Inshallah, they will be happening over time. So it is important to enable value-based healthcare to address the payment model. The current payment model, which is, for example, based on budgets, fixed budgets to a hospital with no accountability of how this money was spent, is not going to continue on. So the payment model and the tools that we use is going to be an important lever. Model of care. We can develop payment models. We could use artificial intelligence. We could do whatever we would like to do. If the model of care remains poor, nothing is going to change. We will not be able to contain costs, for example, if we do not change the model of care. The benefit package is something that is actually existing right now in the private insurance sphere. In the future, there will be also a health benefit package for the public beneficiary. And why is that important? It is important because right now we do not have clarity about what the provider should be delivering. There is no clear limit. So we are delivering high value care and low value interventions. Are we going to be reimbursing those? Are we going to be covering those? The answer is every single intervention, every single medication or therapy or supply, medical supply will be looked at, and a decision is going to be made about whether it's going to be included in the benefit package or not. But it doesn't stop there. And I going to the question that was posed to Dr. Shabab, is that it's not only about deciding what the benefit package is, but the rules that actually dictate the entitlement, the delivery, is also going to be followed through the robust IT infrastructure. Population health management is a very, very, very big topic. Maybe we'll have time to talk about, but we think that that's going to be the operating model for the clusters, and it is going to be our operating model as a payer. This is how we're going to be paying services based on the population health management approach. Contracts is this is our game. At the end, the way we actually translate all of what I just mentioned is going to be through a contract. The managerial cluster, for example, and we would say that this is your, let's negotiate what the budget is for you, but not only that, we're going to talk about the service specifications, we're going to be talking about the targets, we're going to talk about metrics, outcome measures, and all of that is going to be encapsulated, codified in a contract that they are accountable for. And that is going to be a journey. That is not going to happen tomorrow. And last but not least, transparency. And I think that one of the areas that we're working on right now with the Saudi Health Council as a payer, as a proof of concept, is that we're actually working with disease-based registries and trying to collect data or outcome measures, outcome data on diseases from the perspective of what matters to patients. And Dr. Shabab mentioned ICHM, and we're using their minimum data set to measure care in coronary artery disease and in stroke right now. And we're looking at this, and one of the outcomes that we hope to achieve is once we have data and quality of data is the right quality, we would hopefully benchmark providers. And I think that that's something that advanced healthcare systems have arrived at, and we're hoping to get there at some point. So I think that these are some of the areas that we could do in the system, hopefully to deliver value to Noura and Ali.
Dr. Hassan, this is really big ticket items. To hear the biggest player, the ministry talking about payment model, about contract, about healthcare benefit package. This is good, quite inspiring and challenging. I'm just wondering, what's the expected from us frontliners? What should we do differently tomorrow in the clinic to be ready for all these big ticket items that you are presenting to us, Dr. Hassan?
I think that the first order of change is re-examining the model of care. I think that's the first step. So I think that the approach that we're taking right now in our clinics in terms of episodic care, fragmented care, it needs to change, and it cannot happen, by the way, from a change from one practitioner. It has to happen across practitioners, but it has to happen at this. The mindset has to change first. So I think that the first change is the model of care. I'd like to say that at the end of the day, our mandate is to empower the new model of care. That is, how do we actually support the model of care? Everything that we do is really towards that. And I think that the practitioners, if they take that to heart, as a first step, we would move, we would be achieving a great stride forward. And other things will come, inshallah, will be phased in this transformation.
Thank you very much. Dr. Reem, the population health was mentioned frequently throughout your talk, Dr. Hassan, Dr. Shabbat. As the strategy writer for the value-based healthcare, would you share with us how do you envision the role of population health in this transformation?
I can only repeat what Dr. Hussam just said about the importance of population health management, and it's an extremely important dimension because it's where allocation of resources at the higher level, at the national level or at the cluster regional level, is done in order to basically figure out how to use these finite resources. And I'll hand it back to Dr. Hussam in a second to further elaborate on this. But a couple of basic principles are, one is allocation at a population level and understanding what the population really needs the most. If you have limited resources, and I mean, this is like a simple question, if you have limited resources and you have a population that suffers, high rates of obesity and a small number of people that suffer from a less common disease, where would you put that investment? And then when you speak about this population, you speak also about not only about like a disease such as hypertension or obesity, but you also speak about breaking them into segments where you have people that are early diagnosis with hypertension, that have requirements that are different from people who have severe hypertension with end organ damage. The needs, the care plan, the resources that are needed to be allocated to their care are different. And with this, I probably want to hand it back to Dr. Hussam, because I think this question that you're asking is extremely important very relevant to this conversation that we're having on value-based care. So over to you, Hussam.
Thank you, Dr. Areem. Let me just put up my slide again. I think this is a big topic, and I hope I don't really, by abbreviating it, that I would not give it enough justice. But let me just, give you a taste of how that would look in the future. So if you look at the slide, this is a depiction of a fictional cluster. Let's say it's cluster number 2, where you have several hospitals, but they actually cover a population. This is what is happening right now. We do have around 7 or 8 clusters right now running. They have been defined even more than that now. But each cluster is responsible for and by the way, a cluster is a network of hospitals and primary care centers. And they are accountable. These different hospitals follow one entity. They are one entity, التجمع الصحي, the health cluster. They are accountable for the health and healthcare of a population, a defined population. And so let's say that this is the cluster, and this area here is the catchment zone of the cluster, and covers a population of 1.5 million. One thing that will happen in the future, and that's what is being right now going to be piloted as of early next year, is that when we look at patients like Nora, for example, or patients like Nora and the patients like Nora, you look at this population. The first step would be to identify the population of the cluster. And once that population is identified, the 1.5 million, and where they reside, and what hospital, which primary care they should be receiving care at, what will happen is that there's going to be periodic population health assessment through a health need assessment. So a health need assessment is going to be done in the primary care center. Some of it is going to be samples, household assessment. And the objective is to understand the health needs of that population of 1.5 million. Not only that, we will also assess the supply side. So we would need to know, against that need, how many, do we have enough primary care centers? Do we have enough hospital beds? Do we have enough physicians, nurses, etc.? And then once that health need assessment is performed, there will be clear problems identified, and they will be prioritized. So for example, let's take obesity. Obesity will be identified as #1 problem. But by the way, obesity might be a problem, a far bigger problem in one cluster over the other. And so the intervention needs to be customized according to that. So after the need assessment, health need assessment, there's going to be prioritization of the needs, and then a prioritization of the interventions, implementation of the right interventions, and then evaluation of the impact. And the cycle goes on and on. And so if you take, for example, this cluster, what you would end up with, and this is very sketchy, this is an example, you'll have a pool of patients. Some of them are going to be healthy. Some of them will be healthy but at risk. Those are the smokers, for example. Those are the overweight. Those are indulge in risky behavior. And then you have the obese individuals who are a segment of that population, and those who have chronic disease, and those who are obese and have chronic disease. And so you segment your population. The health need assessment enables you to understand what the needs are, but it goes even further. It identifies the population and enables us to segment them into different segments. Once that happens, then you direct the intervention to this particular segment after prioritization. Now, when it comes to resource management, and I think we talked about that. I mentioned that there are finite resources. إذا أنت جاي مثلا تتكلم عن resources, you either have a budget for obesity surgery program, you have a community prevention program. The question becomes, part of the population health management exercise is, what is the biggest bang for our buck? What would be the best approach for the population? And that might be different. The answer to that question might be different. And it could end with something like that. We could be putting more resources into community prevention programs and less in obesity surgery program. That could be the conclusion. It could be the opposite. But I think what I'm trying to say here is that allocative value, which Dr. Arim was mentioning, is a key area of value delivery. We need to look at our resources and we need to make decisions about what will be the best allocation of these resources to maximizing value delivery. So this is in a very short abbreviation really of a big topic that we're all excited about and we think will be very impactful, inshallah.
Excellent. Thank you for the alignment, Dr. Hassan. Dr. Shabab, we all talk about resources, and as physician and healthcare industry, we know that drugs, medication, pharmaceutical are a big chunk of the resources, big chunk of money. And we just got a very interesting question from our audience about what's the role of pharmaceutical company in the value-based healthcare? How can we ensure that as big of resources are well spent?
Again, I think the benefit package or the scheme of benefits include medical services and pharmaceutical care. And the split usually 75-25. So it carries a major component of benefits that we avail as a system or as a payer to our beneficiaries. And definitely, we would like to, as we improve in services, we would like to improve on the quality of medicine that we provide to our beneficiaries national wide. That's why I think the Saudi FDA is really doing a great work by improving the quality of the medication that's coming to the kingdom, improving the quality of medication that manufactured in the kingdom to make sure that any medication that it is licensed to be given to beneficiaries are really good quality. However, all of us as physicians, we are always very attached to brand, and we still have our skepticism about whether the generic equivalent to the brand. And I can reassure you that's the case in the kingdom because we have a very robust surveillance program to ensure that the generic are equivalent to the brand. And I'm sure if it's possible really to promote more from a clinical side point of view for generic and convince our beneficiaries to use it, that will help us as a system to improve the value across the whole benefits. So I think we need as a physician, as a practitioner, as a allied health, to be an open mind regarding what can we offer to the patient, regardless of its generic or brand. If it's the same quality, I would believe our mandate is really to encourage them to use the generic, to use the resources better, and to provide maybe an additional coverage in other areas. And definitely the role of the pharmaceutical is crucial in terms of education to patient, the appropriate use, because the value is also linked to the appropriate use. So I think improving their educational material and maybe their counseling will add a big push to the value.
Can I jump in, Dr. Hadi? Can I build on what Dr. Shabab just said about this? I also think this question is very interesting, and I guess the add to Dr. Shabab's point is, you know, one of the things about this movement that's happening globally towards value-based healthcare is getting everyone aligned on the objective. Public sector, private sector, provider, payer, regulator, and the pharma and medtech. And as this movement is happening globally, the pharma and medtech companies are also changing their strategies. And so, and I'll go to an example from medtech and then back to the pharma question. medtech, typically the company comes to the provider and says, I would like to sell you a machine. This machine is, you know, amazing, and it's going to do these great things for you. And then you buy the machine, and then 2 days later, or sometimes 1 day later, they come with a new version and say, this is even better than the one you bought. And so now they're moving to, instead of selling the device, they sell the service. And I think maybe Hussam in his area of interventional cardiology, the whole solution type of deal is now becoming like a partnership between the company and the provider. And the partnership is to deliver value. And the same we're seeing also in pharma. Pharma is probably more complicated because of the point Dr. Shabab just made about the generics versus the brand. But that is quite the same. And so the alignment, I guess the point is this alignment that needs to happen. And once that alignment happens, the striking the right balance is where value is at its maximum.
Thank you very much.
Dr. Hadi, if you allow me, I'd like to just add to what Dr. Arim and Dr. Shabab mentioned. In addition to this, there is also a movement in terms of the expensive therapies, the high-cost therapies, specifically cancer therapies that cost almost $1 million, for example, a year. And the outcome could be just a survival benefit of about 3 months or so. And there is a movement right now, although that has not, I don't think that's caught a lot of momentum, but it is being something that is discussed. And we are actually in the future looking into this, which is value-based contracting. And the whole premise around that is basically, okay, so I'm buying from you a drug that costs $1 million riyals, but not everybody is actually benefiting from this drug. I'm only going to reimburse you on those who actually benefit from the drug. And so this discussion is happening right now, specifically in highly expensive therapies. But it remains to be seen if this is going to be widespread and whether that will happen here. I hope so. I hope it will.
Thank you very much. Okay, so there is a very important topic that I want to touch with you, my great speakers, before we conclude. There's the variation and lack of standardization was quoted many times during the different sentences. Now, for me as frontliners, what can the Center for Value Improvement here, the FAB, the CCHI, what can you offer me in the front line to help me get rid of this variation? What resources, what plan, what strategy you are having? We'll start with you, Dr. Shabab. How can we eliminate this variation in practice?
Just before we go to that, maybe I see a lot of question around how can we reduce waste moving among providers. I think the first step of value is really to get all the systems speak to each other. We have in the kingdom the private, the Ministry of Health, other governmental sectors. I think if you look to the ecosystem, that's the first step of value. How can we make sure each cluster or each provider are catering care to certain population, so we avoid the double dipping. So I think that's another level of value that we are looking at by the systematic change that it's going through, either the transformation of health in Ministry of Health, or at a larger or bigger scale at the national level when we include everybody under the same umbrella. So that's one of the concepts that I think people need to realize. There is several levels of value, and all of them are really geared toward increasing the potential on how to serve the beneficiary better. The question that you have asked about, just remind me, Hadi.
Variation in practice, and Dr. Hussam also mentioned the maybe low value intervention that we are doing as a frontline.
I think as an expert, Hadi, you know very well, adopting evidence-based is the way to go. And I'm sure evidence-based medicine has been there for the last 20, 25 years. It's evolving now to clinical protocol. And as you know very well, CCHI took the initiative at the beginning of 2020 to work on a small initiative where we are releasing now a 20 clinical protocol to cover maybe a good percentage of our population needs, with a collaboration of several medical society like you and Dr. Hussam. I hope these kind of initiatives support by the regulator will be a good resource for our physician to adopt and to encourage them to use. And I'm sure this will help us to adopt the principle of really doing what matters for patient, doing something to the patient or for the patient rather than doing something to the patient. I think there is two different. So doing something for the patient is really adopting the clinical protocol will reduce the variation in practice.
Thank you very much. Dr. Hussam, what do you like to add?
And we're going to add to this, on the Bayer side, we are working on, as you know, in a health information system, you have something called the clinical support decision. We are adopting this from the Bayer side. We are calling it approval clinical support decision. So when the request for service comes to the Bayer private health insurance, we are now building a tool for them like the InterQual, the Milliman clinical guidelines, to help them really to evaluate the request for the service. Is this request for the right patient, for the right level of care, and for the right protocol?
Excellent. Dr. Hussam, making the standardization for the practice. Dr. Shabab mentioned adopting guidelines. As the biggest buyer in the country, what's your take on this initiative of the clinical practice guidelines or the plans?
Yes, thank you for that question. I think that the clinical guidelines is the first step. It is not the only step in terms of standardizing care. It's not going to be the only intervention that needs to be done. It is really implementing them. It is really embedding them in care, in day-to-day care, and it's going to be really challenging for practitioners to do that simply by looking at a book or an app. That does not necessarily ensure uniformity of care. And so we've developed the ACS guidelines, and Dr. Shabab, yourself, were really very supportive in endorsing them. I think that will be the first step in this, in trying to address the issue of variation. The next step would be to find to follow the best practices in implementation. And one area that I'm particularly interested in is having standardized order sets. And I'm not talking about these fixed, static standard order sets, but dynamic order sets. Those sets that also have decision support tools that will guide you. For example, if you actually click on a medication that you should not be giving to a patient it is not indicated, or you're depriving a patient of a valuable intervention, it will prompt you. And so I think that is going to be important in reducing variation. Transparency is going to be the biggest area, haqiqatan. And I think that without data, without transparency, we won't be able to uncover variations. And by the way, when we talk about variations, we talk about unwarranted variations. We're not talking about variations that are part of the normal practice. We're talking about unwarranted variations in practice. If I was to speak to the practitioner, individual practitioner, what I would really tell him and or her, be it a doctor or a nurse, is documentation, but better documentation. Without having proper documentation, you have nothing. حقيقة nothing. You're going to be coding. So coding is going to be the key ingredient for collecting data. Unless individual providers properly document, we won't be able to actually codify these services, and we won't be able to actually measure, and we won't be able to actually benchmark. So those are some of the areas that practitioner can start doing to reduce unwarranted variation.
Thank you very much, Dr. Areem. The issue of variation and lack of standardization, as a strategy writer for the value-based healthcare, what do you have for us?
I'd like to start by saying something about how we at the center envision our role in this. Our role in this as we go forward would be and building on what Dr. Hussam just said on the transparency issue, would be for us to start issuing reports that actually reveal reveal variation, whether warranted or unwarranted, and then dig deeper into reasons for that. And some reasons for that are solved by not only having clinical practice guidelines, but also applying them and watching how they're being applied, revising them based on the national, local context. In addition to that, looking at other areas, I mean, some other areas or other solutions for eliminating unwarranted variation is streamlining care, where some specialized, even if they're not highly specialized services, somewhat specialized services are concentrated in certain areas where the workflow is more efficient, the likelihood of errors or issues with quality is less, and the cost is also less. I mean, and there are many examples relevant to this audience is type 1 diabetes, where you can have that focused in certain centers, because this is really a special population of patients that can benefit from having their care centralized or focused in areas. Other comments to this is quality. In addition to, we spoke about practice guidelines, spoke about standardized order sets, quality, looking at issues in relation to quality. And then I'd like to go back to the issue of waste, because waste is sometimes a reason for unwarranted variation, and waste is sometimes a procedure that is, or a service or an act that is overused. And the example, the graph that Hussam showed us on the US health system is a good one. And I want to make a statement on waste, because I think this is very important to this audience, because the frontliners are where most of the waste happens. And waste is in requesting a test that's unnecessary, repeating a test. I mean, there was that question about how the health system would function across sectors, repeating tests that were done in another clinic because I think my lab is a better lab or does a different, kind of medication ordering, procedure ordering, or recommending interventions that are not proven to be related or linked to better outcome in certain conditions. And so going back to the point on evidence-based medicine and care guidelines. So that's my build on that discussion point.
So it's 1 minute past 9, and we came to the end of this evening. I want to take one take-home message from each one of my distinguished guests. Dr. Areem, give us one take-home message from your side.
the movement is largely a change in the mindset. So remember that it's a change in the mindset from being a provider that I know better, or, you know, I'm going to dictate what's going to happen, to the reverse.
Thank you. Dr. Hussam, one take-home message?
I think the take-home message is that change, transformation starts with you as a practitioner. Without your participation, your embracement of this change, it will not succeed. No matter how much money we put into this, how much structures and regulations we put, it is up to you as a practitioner.
Dr. Shabab, you want to conclude with one take-home message from your side?
I think I will agree with my colleagues. I do believe in value-based healthcare. I think we should all believe in value-based healthcare. That's my slogan, and I use it in even my bio. So if we believe in it, it will happen. And I'm always optimistic. So أنا متفائل جدا. I'm very optimistic. You know, this will materialize since we see the determination of all of us, from the top of the pyramid to the front line. Thank you.
Thank you very much, and I'm sure it will definitely happen. We have 1,700 active, engaged audience, and we passed the time. Thank you, my great speakers. Thank you, my great audience. Before I conclude, I just want to remind you with our upcoming events on the January 27th. It's about exercise. Mark your calendar. Make sure you join us on the January 27th for one of the evidence-based evening. And please do mark your calendar for a big event, the first Saudi Chronic Disease Conference, 27th, 29th of March, and the deep dive. It's the landmark of family medicine and primary care, gonna happen in June 9 to 12. By that, I thank you all. وأستودعكم الله الذي لا تضيع ودائعه في أمان الله. Thank you very much, everyone.
شكرا جزيلا.
Thank you very much.
باي باي، مع السلامة.
Thank you.